Good morning. Welcome to our November Grand Rounds. Is my mic working? Yep. Before we start, just one housekeeping announcement. We have Dr. Will Lack with us for his first Grand Rounds. Dr. Lack is no, you have to stand up, Will. Dr. Lack is a trauma-trained surgeon from Loyola, and he's splitting his time between Northwest Hospital and the VA. And he has already made major inroads helping us with the ER volumes at Northwest Hospital. And he's even already submitted an R01 grant to the NIH. So welcome, Will. It's great to have you. Our grand rounds this morning, prepared with very short advance notice, I'm impressed, is on adolescent idiopathic scoliosis, current state of the field and controversies. And our resident Kacy J is helping Dr. Jen Bauer, who is now an extremely busy pediatric spine surgeon at Children's Hospital. Thank you.
Thank you, Dr. Chansky. Good morning. I'm Kacy, and I'm one of the R3s. I have no disclosures other than I haven't done my spine rotation at Children's yet, so I feel really prepared. Like any good orthopedic lecture, I think we should probably begin with a history lesson because that's what orthopedics is. Scoliosis comes from the ancient Greek word scoliosis, which means bent or twisted, and its descriptions and treatments date back to the Hippocratic writings and to the father of orthopedics, Nicolas Andri, who not only gave us a few interesting theories on the cause of scoliosis, such as restrictive clothing and poorly made children's furniture, but gave us one of the enduring symbols of orthopedics, the scoliosis tree, which, if you look at our own symbol, is modeled after it. So I'm excited today to be able to present on an ongoing, long debate of scoliosis, which has lasted for centuries, millennia. So for my talk, I'll discuss the current definition of AIS, its diagnosis and imaging, the natural history, and how to predict remaining growth and curve progression. And then I'll hand it over to Dr. Bauer to talk about treatment strategies and controversies. We'll start with a case example. We have a 15-year-old male who comes into clinic with spine curvature and suspected AIS. His curve was first noticed when he was about 10 and then got worse in the past year after a growth spurt. He has occasional pain in his shoulders and back, but no other neurologic symptoms. He tried bracing when he was younger, but didn't wear them regularly. He has no other past medical history and a family history of scoliosis in a grandmother and a sister. Scoliosis is defined as lateral deviation of the spine over 10 degrees. But it's important to remember that although it's defined by this lateral curvature, it's a complex deformity that occurs in 3 planes. There's lateral intervertebral tilting in the coronal plane, intervertebral extension leading to hypokyphosis in the sagittal plane, and a rotary component in the axial plane. AIS is defined by the occurrence in a child over the age of 10 with no definitive cause, making it a diagnosis of exclusion after other causes such as neurologic conditions, congenital deformities, and pathologic processes have been excluded. It occurs in about 1.5% to 3% of the population with decreasing prevalence as the magnitude of the curve increases. The diagnosis of AIS begins with screening, which is an area that we still have some controversy. Most kids come in after being screened by their primary care provider, but school screening programs still exist, though we have no good evidence for or against them. Proponents say that they're good because they pick up low-income children and underinsured who may not have the same access to primary care providers as better insured children, whereas detractors find that they lead to a lot of unnecessary referrals to specialists. Either way, once they come into our clinic, the exam of a patient with scoliosis should include evaluation of the curve and the alignment, looking at the direction and sharpness of the curve and evaluating for kyphosis, looking at shoulder and pelvis height, limb length discrepancies, a full motor and sensory exam, and evaluation of gait and foot arches. Looking at foot arches, for those of you studying for the OIT, remember cavus points to a problem upstairs. And then peripheral and abdominal reflexes. If any abnormal neurologic findings are found, kyphosis or a curve over 25 degrees by the age of 10, it should prompt us to get an MRI to rule out something such as a tethered cord or a syrinx, which might be the neurologic cause of scoliosis. So going back to our 15-year-old male, he's tall and thin. On his exam, he has even iliac crests, his right shoulder slightly elevated, and he has a right-sided curve with thoracic prominence that increases with bending. This is not him, it's just an example. He has no tenderness, and he has a normal neurologic exam. So we move on to imaging of his curve. The standard radiographs for evaluating scoliosis include a standing AP or PA of the spine, a standing lateral, and supine side bending radiographs to evaluate for curve flexibility. In all the radiographs, it's mandatory that all vertebrae be visible, at least from C7 to S1 with a view of the pelvis. The images I provided this morning are EOS imaging, which is a newer form of low-dose 3D imaging that produces a full-length 3D radiograph of the spine, which is becoming more common in academic settings, though if you receive scoliosis films from an outside provider, you're more likely to get the longer cassette films of the past. It provides 2 to 3 times less radiation and makes consistent images that decrease the chances of poor quality radiographs that may need to be repeated and expose children to unnecessary radiation. It also allows us to image the entire skeleton, which we'll find is important for using other markers of skeletal maturity, and I'll talk about that a little bit later. The measurements that we obtained from these images include the Cobb angle, evaluating the magnitude of our curve, the central sacral vertical line, looking at coronal balance, and the C7 plumb line, which is measured from the center of C7 down to the posterior superior plate of S1. And looking at our patient, we can see that he has a main thoracic curve from T5 to T11 of 63 degrees, a thoracic curve of 42 degrees from T1 to T4, and a non-structural lumbar curve from T12 to L4, which you could see was non-structural based on the bending films. So based on his exam with normal neurologic findings and his images, we've diagnosed him with scoliosis. And the next question that parents and patients have are, what do we do about it? Can we observe it? Do we need to brace again? Can we go to a chiropractor and get adjusted? Or do we need to get surgery? And to answer those questions, we have to be able to understand and explain to patients the natural history of the disease. In the 1970s, Nachemson and his colleagues published a 38-year follow-up of Swedish patients with untreated scoliosis and found some pretty terrifying results. About 40% of patients with untreated scoliosis were disabled due to their spinal deformity. They had significantly higher rates of back pain and cardiopulmonary disease, and their mortality rates were 100% higher than the normal population. So you can imagine getting a diagnosis of scoliosis after that paper would have been pretty devastating. But looking back at his studies, not all of these patients had AIS. They were sort of all comers of scoliosis, so neuromuscular disorders, juvenile and infantile idiopathic scoliosis, all of which have different progression and predicted outcomes compared to AIS. So luckily, the state of Iowa produced one of its big accomplishments with Weinstein and Ponseti, who followed 194 patients for decades and reported on the natural history of their patients' clinical and psychological outcomes. Contrary to the reports from Sweden, they found no evidence of increased rates of disability or pain, and they had normal mortality compared to the general population. They also established some risk factors for scoliosis, which have been proven by multiple studies and continue to be studied in other populations outside of Iowa. These include sex, with female patients having greater prevalence of larger magnitude curves. For curves over 35 degrees, there's about a 9-to-1 female to male ratio. Curve magnitude is also a risk factor for progression, with curves at or under 30 degrees being unlikely to progress after skeletal maturity, and curves of 50 degrees or more being likely to progress 1 degree per year and having a higher risk of some cardiopulmonary effects later on. Curve pattern also increases risk of progression, with thoracic curves being more likely to progress than thoracolumbar and lumbar curves. And finally, which will be the remainder of my talk, remaining growth. Remaining growth, especially when taken in the context of curve magnitude, determines how much a curve is going to progress over a patient's lifetime. So predicting how much remaining growth a child has is essential in determining what treatment strategy we're going to pursue. Unfortunately, there's no perfect way to do this, and or know when a child's peak growth is going to happen. So that's why it remains an ongoing academic and clinical pursuit for surgeons who treat AIS. It can be predicted clinically or radiographically, with clinical signs of maturity such as menarche in female patients and physical signs of puberty occurring after a patient's period of rapid growth. So if those are being used as our markers, we're really seeing a missed opportunity to intervene on a patient's curve progression. So the main clinical measurement we use to predict curve progression is peak height velocity, which is a measurement of the maximal skeletal growth that occurs during the adolescent growth spurt, and is calculated based on the change in a patient's height over time. The period of most rapid growth in adolescence occurs in the 2 years before and after peak height velocity, and in the average age for females is about 11 and a half years, and in males is about 14 years. Unfortunately, peak height velocity is generally a retrospective number, and it's difficult to obtain frequent enough data points to be able to calculate it. So we use surrogate markers of skeletal maturity to predict rapid growth, with the historic standard radiographic marker being the Risser sign, which uses the ossification of the iliac apophysis. Unfortunately, a child's most rapid growth occurs before Risser stage 1 and fusion of the triradiate cartilage, leaving a significant amount of time when we don't know what is happening with a patient's growth. Other markers of skeletal maturity have been developed, with the most commonly used markers in the hand and wrist. The Tanner-Whitehouse method was the first to be produced and is based on physeal changes.
I'm going to skip forward. This is an important part of the talk that I think we'll be able to get back to here, talking about predicting whether or not the curve is going to progress, and therefore whether or not we should be bracing or observing or doing surgery. So I'm going to continue on a little bit here and talk with a focus more on the surgical aspects and sort of the current controversies. The part of the controversies that we're talking about is how to predict the skeletal growth, but the next controversies are all in the basis of what to do when we get to surgery. So we've already decided that our patient likely needs surgery. We're going to talk a little bit about Schroth physical therapy as well. We'll try not to get too bogged down in the surgical details. So what I'd ask from you all here is to try to consider what you might have similar in strategy or technologies that you use in your subspecialties across all of our subdivisions here, to see how you might have some better ideas of what we're doing, give some fresh ideas, fresh eyes onto what's going on. So here's our patient again, the one that Dr. Peak has presented to us. And again, you see this 3D deformity. And so we know that this curve is 63 degrees. This patient has actually already been braced and failed because the curve is beyond 63. But we can ask ourselves, is there anything else we could have done for this patient before we get to the point of surgery? Some people might say yes. Schroth therapy, you guys have probably heard of it. If not, someone on your street or your neighbor or your aunt is going to ask you about it. It's a physical therapy that's exercise and motion-based to try to teach children how to hold their bodies in a certain way against their curve, using their muscles as their brace. Proponents point to the fact that there have been some studies showing that there is a relative decrease in the progression of a curve. In order to achieve that decrease in a progression, 4 patients need to be treated for 1 patient to have decreased progression. We've seen that it works better on smaller curves, younger curves, more flexible curves, which makes sense. Everything would work better on those curves. And we've also seen that it really works much better in conjunction with bracing. So here's a study looking at curves between 20 and 40 degrees, following it out for 18 months, and as long as they also did Schroth physical therapy, they did not progress. And those who were in the brace without physical therapy, they were found to have progressed. This is the photograph, however, from that same study showing us their best case scenario, because that's why you would put it in a paper, and they look the same to me. But maybe that's the point. Maybe the point is that we can keep these patients from progressing by adding in this physical therapy to their brace treatment. So this is the official Scoliosis Research Society statement on Schroth physical therapy, and we state that there's no evidence supporting it to be offered in substitution of bracing. So for me and my patients, I offer it to them. It is very time intensive. It can be very economically costly, but I tell them it might help, but it certainly doesn't hurt. So if someone is treated successfully non-operatively, they have reached skeletal maturity with a controlled curve. Any one of a combination of those things under skeletally mature would be accepted as the fact that they're done growing. I like to see more than one of those, ideally a Sanders 7 score, which we'll get back to, which is a hand score, and some other combination of decreased growth. That's when you can stop the brace. And if they can get to that point with a controlled curve or a curve less than about 40 degrees, that curve shouldn't progress for the rest of their life or give them any problems. But what do we do back to our patient? This patient is still skeletally immature. His curve is over 50 degrees. So this curve is going to guarantee to be continuing on in size throughout his life, and so he's offered surgery. So Dr. Peak talked about our 3-dimensional deformity again. Anthony, give me one deformity. Which plane? Give me a plane. Perfect. So coronal tilting, 63 degrees. Mark, give me another plane. Awesome. And what does it look like on sagittal plane? What's the deformity? Great. You can see how it's almost lordotic there through the thoracic spine. Aditya? Great. And how can you tell that on this x-ray that there's rotations? You can tell something on the AP and you can tell something on the lateral. Great. And sometimes an easier thing to look at on the AP are the pedicles, because the pedicles are shifted, and you can see he's got a huge rib hump here. So that rib hump is rotated out backwards towards you. So he has failed, he's skeletally immature, he has a large curve, and he has a 3D deformity. Surgery just follows some simple steps. Sometimes it can take a long time, but it's really all boils down to these simple steps. But at each step of the way, there's some sort of a controversy that we're currently grappling with in our literature, and we'll go through quickly some of these. So when the first step is to actually plan and pick which levels, and that's based off of the Lenke classification, which is here and is essentially out of scope for us today, I think. There are a lot of rule breakers. There are a lot of alterations and different interpretations occurring right now in the literature. This is the best guide that we have, so it's the best place to start to decide to pick your levels on where to fuse. And it's based on which curves are not flexible, which curves don't bend out, and how big the thoracic curve is relative to the lumbar curve as to which curves you should fuse. So all surgery starts with the exposure. It's followed by wide facetectomies, where we cut the inferior facets here, the inferior articular processes, to open up the facet joint. Then we're going to place screws. And this is one of the first areas that we're going to talk about with some debate. So the debate centers around how to place it, whether to place it with a freehand pedicle finder versus a more technology-focused CT navigation. We found that with freehand place screws, if given the chance to review them by CT, that you would want to redirect screws in at least half of your cases. But in order to prevent an operation, if you would have to come back to replace a screw if you hadn't done that CT, if you were out of the OR and then did a CT, you would need to CT 76 patients, because although those screws you'd like to change, they aren't necessarily clinically important. So here you can see an example of a screw that actually appears appropriate on the radiographs. It doesn't look long, it doesn't look lateral, but it's actually tickling the aorta. So we can be tricked. That's why the proponents of CT navigation like it. Now it comes at a cost, financial and radiation to the patient. And the most recent meta-analysis is starting to swing away from it a little bit. It's agreeing that there are more pedicle breaches, meaning the screws are cutting out of the pedicle just a bit at some point with the freehand technique, but they're rarely clinically significant. So I rely on freehand placement with these oblique radiographs to augment whether the screw is out laterally or too long, in addition to the lateral and AP radiographs. The second concept with screw placement is the density of the screws. How many of these screws should we put in? Some curves are just more flexible and you don't have to put in that many screws. Other curves are stiff and larger, and you want to put in more screws to decrease the amount of force in between the screw and the bone interface. Of course, screws all cost money. These are very expensive operations. And so with the rising costs, there's a fear of decreased reimbursement, and that has influenced this MIPO clinical study, which is going on right now around the country. MIMO. It's Minimal Implant Maximum Outcome Study. And you can see they've done this literature review. All of the red there is how much curve correction they've gotten in all these other studies that have used a varying amount of screws, that being the blue bar. So you can see even when the blue bar doubles, when we use a double amount of screws, we're not necessarily getting a better correction. So that is what has spurred this on. However, the only correction they're looking at is the correction in the coronal plane. And we're going to talk about a little bit about how you can use your screws and your correction to get the other two planes. One of the ways to do that is the rod placement. After we place our screws, we're now going to place our rods and hook the screws up to the rods. This is part of manipulating the spine. So Brett, what are you going to ask anesthesia to do before you start putting your rods in? So they're going to be pretty paralyzed. They're going to be pretty deep. We've been keeping our pressures low because we don't want to bleed much. Now we're going to put the rods in. Exactly, because we're going to be moving that spinal cord, stretching it out. So we want to make sure our maps get up to 80 right before we start placing our rods. So the shape of the rod can actually impart reduction force. And one of the more recent ways of doing this is to shape the rods differently. These are drawings of two rods that I've bent. The straight one is there that you're seeing now, and then I'll make a more curved one. This is called differential rod contouring. I'll use the more curved one on the concave side to pull the spine up to it. I'll then use the flat one to cantilever down that right rib hump and push it all the way around to try to rotate it around. Here you can see in this comic how you can pull the curve up to a more curved rod, a rod that has more kyphosis, to bring that hypokyphosis out and that concavity out. And here you can see these rods that are measured here, I used in this patient. And you can see how they actually are lined up now, despite how differently they're shaped. And you can see we got a bit of kyphosis out of this kid who didn't have really any kyphosis to start with. This technique was just validated this year using 3D measurements. And the opponents of this technique say, well, we used CD rods for years, those rods that were just straight and flat and gave a flat back. So that's the concern. But there are some studies that point to the fact that these patients with flat backs after scoliosis surgery when they're adolescents actually have done okay. So there's a lot of ongoing research of, do we really need to restore this kyphosis and rotate this around? In order to loosen the spine, in order to bring it back up to us, one of the things we can also do is do posterior column osteotomies. Now in reality, I do my posterior column osteotomies after exposure and before screw placement, but you can do it at any portion. Some people do it after their screw placement. So we will have done our exposure. We'll do our facetectomies where we take out that bone that's colored in yellow. Here you can see these cuts taken out. And here are ponteosteotomies at the levels just below it. You can see that the spinous process has been removed, the ligamentum flavum, and there's been an osteotomy or a release through the superior articular facet so that the entire posterior column now has been released. Here's more of a comic. There's been sufficient papers that proves that this does cause a correctment, or it improves our correction in all three planes, but they carry inherent risks. This is the only paper to really examine the risks of it, done recently, and there is a higher percentage of neuromonitoring changes, but this isn't a statistically significant neuromonitoring change difference, actually. And if you look at the studies, this improvement in our correction, it really only amounts to maybe 3 to 6 degrees. So back to our patient again. We've discussed that this child has a three-dimensional deformity, and we wanted to improve all 3 planes. So we can improve the coronal plane by compressing and distracting the screws along the rods. And the sagittal deformity, we used our rod shape to pull it out into kyphosis. What's our one deformity that we're left with again, Aditya? Right, so we still want to derotate the spine. So to derotate, you have to use screws that are fixed to the shaft so you can have it fixed in a bone and move it along, not just screws with the head that will move as you change the head, because the head has to be able to slide along the rod and then be locked down to the rod. So there's 2 different ways to do it, en bloc versus segmental. Here's segmental, where you're just going to rotate one level against itself and lock it down. And the other one is where you will hook up several levels together and rotate them against each other in an S-like form. So here you're rotating against each other and then you're locking it in. Brett, being critical here, which one did we do a better job derotating, the lumbar spine curve or the thoracic spine curve? Right, because the screws are all pointing medially. And in the lumbar spine, we can use our x-rays to really determine how well we did derotating because the screw tips are not all pointed medially. So we can be a little bit critical when we look at our x-rays and determine that. But you can see where we started from in the thoracic spine when we just placed our screws, and then where we got to when we derotated. Studies have shown that there's no difference between en bloc and segmental, and you should just do what's best for you. But some recent studies have shown now that even though you're derotating the spine and the ribs come with it, they slowly come back, and over 2 years' time, it doesn't actually matter if you derotate it or not. We need some more study on this. Because these studies are also looking at East Coast curves, I call them, curves of about an average in the low 50s, and we have different types of curves here on the West Coast, I've discovered. And maybe just our screw density is actually the most important thing for the derotation. So we're going to be faced with some larger curves sometimes, some very large curves, and we can use some other manipulative tools. These are a bit debated as well. So sometimes a curve gets very bad very quickly. This is a 6-month difference. Just based off of what Dr. Peak just showed us, where do you think peak height velocity happened? Sometime in between that 6 months, right? All of a sudden this girl shot up. The faster you grow, the faster the curve gets worse. So this is what she looks like. She went from a 60-degree curve to a 120-degree curve. And so in order to get her straighter, we can actually use intraoperative traction, where you put their head in a Mayfield head holder and pull weight off of their legs in various types of ways to get her a bit straighter than you might have otherwise. You can see also the rib hump there and the realignment. One other topic of discussion are doing concave rib osteotomies. These have their risks if you're going to release ribs, but I will use it on curves that are very stiff. So this is this patient's max bending curve. She went from 54 degrees to only 49. So I didn't have much confidence that I could get her very straight with my usual maneuvers. And so in surgery, I actually cut her ribs just lateral to the transverse processes and took 1 centimeter out of each one. You can see just the cuts here before taking 1 centimeter out. You can see how the ribs are allowed to shift, and then you can get a much straighter spine. Here's another example. You can see how close these ribs stay. If they're not going to splay out, then this curve probably isn't going to get very straight. And here I did rib osteotomies as well. The biggest controversy is for what? Why are we doing all this? Why are we cutting girls' ribs and putting pins in their skulls and going so far as to take all these steps in order to try to get this straight? We know that doing all these steps leads to a longer operative time, a higher EBL. Many studies have shown that. It increases your surgical site infection risk just by nature of bleeding more and having a longer procedure. And there's really no proven SRS 22 score improvements, which is sort of like our short form or any other sort of, it's our basic reported outcome score for scoliosis. But I would argue that these kids, yeah, they do great. They have 50 and 60 degree curves, so their SRS starting score is wonderful. They can do everything they want. We're pulling them off of the soccer fields to fix them in order to keep their curves from getting to 80 degrees later on in their life, because curves over 50, the majority of them are going to get worse by a degree a year. So here's just a couple more examples. This is a patient that we've shown you before. You can see how we used increased screw density to pull the spine over. We're able to create some kyphosis and flatten out that rib bump. This is a 1-year follow-up. Here again, we didn't have to use as much density. And the operation that we've been showing along the way was actually one that we just did Monday. This is that patient. Correcting the curve here. So back to our original patient here. This was his x-rays that we've been following. And this is his correction. And this is his sagittal correction here. How are you feeling? Do you want to do it from the chair? Or you want me to do it? You do it from the chair, though. I'll do it. All right, we're going to head back up here in hopes that we can save some people from surgery, because it's a little gruesome, but it's fun. To talk still, oh, you want your notes? Are you sure? To talk about who we might be able to save from surgery. So just to bring you back to where Dr. Peak was talking about, we're trying to figure out who we can catch, because we want to catch them while they're growing and see if we can do something about it. We want to catch them before they're growing. So is there a way that we can catch them before they're growing?
Sorry about that little interlude. So I was speaking about peak height velocity and how we calculate it. Most people who studied scoliosis before the 2000s were familiar with the Risser sign, which I talked about. It looks at ossification of the iliac apophysis. But the markers we use now are markers in the hand and wrist, which started with the Tanner-Whitehouse 3 method, which was found to be pretty cumbersome and required an atlas, which I think anything that requires an atlas probably isn't going to be used anymore. So naturally, we trimmed it down to create the Sanders score. The Sanders classification was developed as a simpler method of calculating skeletal maturity. It's based on the progression of digital phalangeal and metacarpal physeal closure, which progresses from the distal phalanges to the metacarpal heads. And it assigns patients a skeletal maturity stage of 1 through 8, with 1 representing juvenile age, which is displayed here on the right, with the most potential for future growth, 3 representing the approximate time of peak height velocity and most rapid growth, and 8 representing full maturity. So you can remember that Dr. Bauer said that she likes to see someone who's at least a Sanders 7, meaning they don't really have any growth remaining. And at stage 4 and beyond, we know in adolescence growth is slowing down. So curve progression to greater than 50 is fairly unlikely with most curves. By using the Sanders classification, we can predict the likelihood that a curve is going to progress to over 50 and necessitate surgery. So when we look at a patient with 25-degree curves, a patient who's skeletal stage 2 has an almost 100% chance of progressing to 50 by the time they reach skeletal maturity. While a similar patient with the same size curve who's skeletal stage 4 has essentially 0% chance of reaching 50 degrees. And it's important to note that these stages both occur before RISR 1, meaning that if we only predicted curve progression based on a RISR stage alone, we could easily overestimate a patient's likelihood of progression and give them false information about how to treat them. So if we look back at our 15-year-old, you've seen what his correction looks like, but why did we feel that he needed it? So he's a RISR stage 3 with his iliac apophysis visible here, but not reaching the posterior ilium. And I know these hand x-rays are a little bit harder to see, but if you look at his distal phalangeal physes, they've closed on all of his digits, and all of his middle and proximal phalanges are capped, and the metacarpal heads are wider than the metaphysis, making him a Sanders stage 4. So that tells us that he's past his peak height velocity, but he does still have some growth remaining. But Sanders classification isn't perfect, and we're always looking for something better, or at least something easier. So a few newer classification systems have been developed. Hung et al. Developed the TOSI score, or thumb ossification composite index, which looks at the thumb epiphysis and the adductor sesamoid. They found that it's highly interchangeable with the Sanders and Tanner-Whitehouse 3 stages, with approximately 73% concordance rate to each of the individual stages of both. And it makes a pretty picture. And then fresh off the press from the Scoliosis Research Society is a humeral classification that was developed by Brian Smith at Yale, which looks at the closure of the proximal humeral physis to predict peak height velocity in stages of pubertal growth. He found that the humerus also correlates well with the Sanders classification, and when combined with either the Sanders classification or a patient's height, age, and sex, it can predict peak height velocity within 3 to 6 months, which is pretty impressive considering the curve progression we saw in one of Dr. Bauer's patients who went from 60 to 120 degrees in that time period. In addition, because the classification is based on the humerus, which is included in even standard scoliosis films, the patient doesn't need any further imaging, and especially with our EOS films, we can potentially take images of the spine, the humerus, and the hands, and take all of those classification systems together to create a good prediction of a patient's peak height velocity. So finally, I know it's a little bit out of left field, but I'd be remiss if the week of the OIT I didn't leave my classmates with something as a reminder for a very tested topic. The BRACE study, which looks at who do we brace and when do we brace them, was published in 2013, and it was a multi-center randomized control trial looking at the efficacy of bracing versus observation of non-surgical curves in patients with AIS. The criteria for bracing, this will come up, is patients with a 20 to 40 degree curve who are skeletally immature, and in that study that meant RISR 0 to 2. They didn't talk about Sanders classification there. And they had 72% success with bracing versus 42% observation, so the study was stopped before it could even be completed because of how successful it was. And they also found a 13-hour per day minimum brace wear time to actually be effective. It's not 18, that's not the test answer. So that brings us back to our patient. We've already sort of seen what to do next, and thanks for understanding a little bit of, I guess, presentation day jitters and being a little bit sick.
And Kacy deserves a good round of applause for rallying. Big picture here, we want to get someone to the point where they're done growing and their curve is small. We can do that with a brace while they're still growing. They need to wear the brace for a certain amount of hours a day, 13 for your test. 18 for my sleeping at night, because they're going to not actually hit 18. if we get to the point where we need surgery, we do surgery not because a 50-degree curve is preventive of life and activities, it's because an 80-degree curve 30 years later is a lot harder to deal with. And we think a majority of them get worse. And we know that those that really truly progress once they start to hit 60 or are skeletally mature at 50 and start to keep inching forwards, that's why we keep watching them, those are the ones that we're operating on. Okay. Questions? Oh.
Thank you, Dr. Peak and Dr. Bauer. That was excellent. I think Kacy was channeling Dr. Diab with her introduction to the topic. I had a question. So you can do a short fusion in an adult, and within a couple of years, you can see adjacent segment disease. And so you have these huge lever arms. And so what happens to these kids' cervical spine, their lumbar spine, their hips? Is there any long-term data on that?
Yeah, it's a great question. Anytime you present this to adult surgeons, they get very nervous, rightfully so, because they're seeing the downstream effects of this. We know very well that if you stop a curve at L4, that you're pretty much guaranteed to have early breakdown, early degenerative discs below. It's not as bad if you stop at L4. When you stop up in the thoracic spine, although it's a large lever arm, it's within the rib cage itself, so we don't see as many effects from that downstream. And so that's why there really is a pretty big push to try to do, leave the lumbar spine alone and try to just fuse in the thoracic spine. We try to counsel our patients that when we do it, their curve below might progress and we might still have to come back. So it's definitely a concern. We don't have really great long-term evidence on how stiff these new constructs are and what that will do. We have good long-term evidence on the CD rods, and it's not as, like I said, it's not as bad as we think. It might be that these very stiff constructs with all these screws and these rods lead to worse outcomes because it's not quite as flexible. There's not a little bit of bend in the system. We don't know that yet because these, we need some 40-year studies.
Thanks. I should just mention for people watching remotely that there is a number on the screen if you want to text a question, or you can also text my cell phone.
Yeah, we got one question. What is typical SSI rate? The surgical site infection rate in AIS surgery is about 1 to 2%. It depends where, what institution is presenting their data. That compares to a surgical site infection risk of a neuromuscular child, so a child such as someone who might have cerebral palsy. That curve correction has much higher risk, anywhere from 10 to 20% infection rate.
I have a question from Dr. Belababa, and it is for Dr. Bauer. Why not use fixed angle screws to decrease cost substantially? You would think these would work well in a pediatric population with flexible curves.
So what he's talking about are probably monoaxial screws. So we talked about the heads of the screws moving. So one head can move all around. That's called a polyaxial. One type of head is uniaxial and only moves up and down like this. And one type of head is a monoaxial, completely fixed. We have worked out various aspects of our contract as far to get all of the screw costs actually lower and quite closer together. But a monoaxial screw is still cheaper. The reason we don't use it is because when we place the rods in, we place a lot of stress on those screws. I don't use a polyaxial screw, but I will use a uniaxial screw because it allows for that head to have more play on the rod, and it decreases the amount of stress and force that the screws see at the bone-screw interface. So although these seem like really strong, great patients, and you're comparing them to osteoporotic adults, a lot of these screws, particularly at the apex, will pull out if you put too much force on them in your correction maneuvers themselves. So to stress out that head just a little bit to get that screw, to get that rod to line up into the head, instead of being able to bring the head to the rod and having a little bit of play in that head-rod interface, allows me to decrease the stress that the screw is having on the bone to decrease the risk of pulling out. Some of these screws in the apex don't actually have any pedicle at all, and they end up being an out-and-out screw where you're just firing them into the lateral side of the body, and really they're not having any sort of a bite into the pedicle at all. So for a lot of areas of the bone, we probably could use monoaxial and the screws that have good, strong pedicles.
Thank you, Jan. Thank you, Kacy. I have an academic side of this for the residents, and that is that prior to 1954, all scoliosis was thought to be due to polio. So we have left out, and we can't include all the etiology discussions here today, but I'd like the residents to realize how challenging the etiology is here. Since that time, our scoliosis continued after the polio epidemic was given a vaccine in 1954. And so now we truly have an idiopathic scoliosis without an etiology. A couple things that have been learned since the Scoliosis Research Society started in 1963 is that if we take this same group of patients and put them in a dark chamber and spin them around, they give a different answer as to where they are. Well, that's a pretty interesting etiology as to whether this is a central phenomena. And we get closer and closer to believing that the etiology of scoliosis is still challenging, and it may be a neurosurgical etiology. And so as we go here, I think I challenge the residents to really think about what's going on. We certainly have the genetic studies that are exhaustive, but they show that we now have 5 and 6 generations of scoliosis and that this is a dominant gene. But it still doesn't give us the etiology. So I realize it's way outside this lecture this morning, but I think it's really a challenge.
No, that's a great point. Two things. One, that polio confounder is really why that first study from the 1970s, that included polio patients as well, that we weren't quite sure what was going on. That's probably why the mortality existed the way it was. So that's a very important historical aspect. And the other one, talking about spinning a patient around the room and not knowing where they are, actually the newest studies that are coming out are looking at the genes surrounding your cilia, so what you have in your inner ear, and also potentially all over on all of your cells that give you some proprioception from every cell maybe, and that might be the actual genetic basis for it, and that's where a lot of the genetic studies are going right now. It's pretty interesting.
Yeah, thanks for the talk. I'm happy that you mentioned cilia because actually that was discovered in zebrafish, which we study. Talking about the genetics, so we know that there's a genetic component to AIS, and so I was wondering to what degree, if you have a family member that has AIS, and they're showing symptoms, how that affects, how sort of a family history affects clinical decision making.
Great question. So we, just because somebody has a parent that has scoliosis doesn't mean that they are going to get scoliosis, but they do have a greater chance of it. Same with siblings, all shared genes. So if I have a child that comes in with scoliosis, whether or not their parent has it or not, I will ask the parent to bring in all of the younger siblings to the next visit, or if there are younger siblings in the room, I will check everyone's back because I know it runs in the family. If the mom has scoliosis, all the more reason for it. Generally, again, this is a female 9-to-1, so it's oftentimes the mom or the grandma or the aunt. It's hard to pre-treat this. So if you have a curve of 15 degrees, the mom had surgery, the grandma had surgery, we know this kid is doomed. You don't benefit from putting a 15-degree curve into a brace because there's nothing to push on. The brace needs to push on something. So that's why we still wait. But I'll start bracing them at 20 definitely before I hit to 25. Or if I think I can't figure out when their peak height velocity is going to be, I'll bring them back at 4 months instead of 6 months. I'll keep a much closer eye on that. So it does impact a little bit of how we treat them.
The shock therapy, there's so much in the history of pediatric orthopedics that has gone through these phases of different types of physical therapy for in-toeing, out-toeing, flexible flat feet, for everything. Scoliosis, shock is not the first time people tried physical therapy for scoliosis. Why is this one taking some traction? Because again, that's the history of pediatric. So Nicholas Andre, he was basically a therapist. And his whole book was about treating in-toeing and out-toeing with therapy, about treating flexible flat feet with therapy. He was a physical therapist, essentially.
Yeah.
So why is this one getting traction?
Because there are studies that show that it may decrease. My partner, Dr. Blumberg, put it best, I think, when people come in to take an x-ray, their Schroth physical therapists tell them to stand in the way that they do for their Schroth physical therapy, which means to try to, if they have a curve like this, to try to straighten it out. So they might straighten it out, but it's going to take their body over here and they take an x-ray, and so we get questions, should they stand with their Schroth posture or not? And Dr. Blumberg recently told them they should stand exactly like that if they plan to stand exactly like that the rest of their life. So I don't know if they're standing that way in their x-rays. I will say that patients that do Schroth therapy often tend to be the more motivated ones. The family is kind of gung-ho. They're very educated. In my patient population, that tends to be the kids who also wear their braces, who are in a lot of sports and have good, strong core strength to potentially to begin with. So there are some confounders there. But I will say that I don't know how many patients I've had who are doing Schroth that really did progress. Have you had many?
There's so many confounders.
Yeah.
Given the number of confounders, the severity of the curve, and the curve type, I think it's really hard to sort of parse it out, and that's something that's challenging. My question for you, and this is something that the study that was published with the brace and looking at how many hours a day do these kids need to wear the braces. They had great data because they had temperature monitors in the brace, but to a certain extent, we have no idea how long these kids are wearing the braces, and that might be the biggest indicator as far as success, and we can't quantify that currently with what we have at our setup. So, yeah. But for Kacy or for you or either one, what do you tell the 14-year-old girl who's done growing with a 48-degree curve? What is your sort of counseling, and how does that, knowing the natural history, knowing that this isn't, you can't make it look 50 degrees on the x-ray, but 46, 48 degrees, how do you talk to them, and what are your thoughts in terms of guidance?
Kacy has not been in clinic yet for spine, but what would you say? You see what surgery is, you see the risks.
Yeah. Well, I think that, one of the things that came up, especially in the first natural history studies, is that one of the biggest effects that they notice in patients with larger curves is the psychological effects of it, and especially the psychological effects of their appearance. So I think sort of understanding how the patient feels about that is a good place to start. Like, how are they feeling about their curve in the beginning? And then I would think about, explaining that this is a borderline curve, and there's a degree of us not measuring it perfectly, and so that puts you on the line of, this is going to progress, it's going to affect you later in life, and you may feel perfect now, but I think it's kind of like Dr. Bauer said, we want to make you have a long, happy, active life for forever, and not just while you're a young, healthy child. So I guess that's one way that I would think about it.
I think the psychological thing is important, but the risks are real.
Yeah.
So after experiencing some of them, I'll tell them. I think you can really steer them one way or another. You can tell them they can be paralyzed, or you can tell them you can make their back look perfect, and you're going to steer them one way or the other. I really will not operate on a curve that's not progressing in a 14-year-old that's 50, low 50s, 51, 52, 53 or less at this point. I'll tell them there's no rush. We can keep watching you year after year. If it really starts to progress, then we can do something about it. But it's not worth the risk at this point. And a lot of girls you've seen girls who are thin, 40 degrees, with a big curve leave crying because you won't operate on a 40-degree curve. But I think we're doing them a disservice if we operate on them.
I'm sure the answer is dependent upon the type of surgery, the length of the fusion. But are there activity restrictions after these kids recover from these surgeries?
I have very few activity restrictions. At 6 months, they can pretty much do anything except learn how to ski or snowboard that winter. I don't like them going back to wrestling, but I'll let them go back to football. I'll let them go back to contact sports and horseback riding. Usually, the big things that I'm worried about, I'll wait till a year. But wrestling's probably the one thing that I don't ever really want them to go back to, and trampolines, of course. There's a question. Oh, we got another question up here. Question from Prosh. Hi, Prosh. Mental health conditions like depression and anxiety are frequently comorbid in this patient population. Is there any evidence of poor postoperative outcomes in adolescents with coexisting mental health conditions, and/or do those conditions improve at all after surgery? There have been some studies looking at patient-reported outcomes surrounding BIDQ and the SAQ scores, which look at sort of patient confidence and self-worth. I'm actually looking at that right now to try to decide which of those measurement items works best at actually predicting that and correlates best with the curve. So we're going to be looking at that as well.
So I have a little bit different perspective of now because I did pediatric and I did both. So what happens when we are in children's hospital, you lost the follow-up after what happens after 22 years, right? I think Dr. Wagner agree with it. So the issue is how hard we are trying to get not the corona correction, also the restoration of the kyphosis. And which patient you're going to try harder to get the kyphosis?
Oh, which patient am I going to try harder to get the kyphosis? I think everything comes from your pelvic incidence. So you really have to look at your pelvic parameters because those are set. We know that those aren't going to change. Although this year at SRS, there were a number of studies that showed that by changing different parameters higher up, the PI actually ends up changing. And so the kyphosis can influence the PI, which is the first time that really that's had some traction. We're talking about a few degrees, so I don't know if this will actually bear out in pure reviewed articles, but it's on the podium at this point. So I think you have to look at the PI. If the PI is high, then you know that they want to have more lordosis in their lumbar spine, and they want to have more lordosis in their, or more kyphosis in their thoracic spine. Those are the ones that I'm going to really try. If everything's pretty flat, so be it. That would be what I do, but I'm very interested to hear you have a much different, a more broad perspective and dealing with patients who then, adult patients with flat backs and other type of deformities.
Yeah.
I guess I want to know if I'm doing something wrong from your perspective.
No. I think that's probably the answer I'm looking for. And then the question Dr. Chansky started with the how's the long-term effects. I think there is no studies which is like coming up for 20 or 40 years after what happens with it. But we see the patient which is not achieved good kyphosis in a high PI patients, and then they suddenly start at the age of 50 or 60, they lost all the disc and their lumbar spine becomes flat. Their patients gets pretty bad in the sagittal balance because the thoracic spine is pretty flat, so everything becomes flat and they're leaning so much forward.
And do you have an idea of what that mismatch is, what I should be
So usually
size-wise?
the PI is, so what happens is the PI is basically it's a slope of the sacrum. And if you walk on the four legs as we are a million years ago, our spine goes this way. So usually, we have a big study we did in India. So we thought like a lumbar spine is always kyphosis, right? Lordosis. But that doesn't match with animals. Animals having a longer lumbar kyphosis. So we did the pig study with we fused the spine and the lower, and we tried to get the lordosis, and second day the pig is having a paraplegia because he had a distal junctional problem, and then they develop a Justin level disease. So we developed the lumbar lordosis to match the PI, and then we developed, now our spine goes in this way, so match thoracic kyphosis to catch our head on the pelvis. So I think it's if you match the PI, it should be the good, but within the 10 degrees should be the goal.
Do you think we should be doing 3-level osteotomies in order to get that?
I think the question becomes, Ponte is not just because the corona correction. I take Ponte's
100%.
as a kyphosis correction as well, so you can distract it and then make a more gap and get more kyphosis out of it.
Great. Thank you.
Yeah.
Because I think that you're really torqued into awkward positions wrestling more so than back. Well, you're getting more so than football. You're getting a high impact. You're padded. You have this impact, but your body isn't being turned into such unnatural positions as in wrestling.
I think that's a good
There's
answer.
no data. No data. Level 10.
And then my more scientific question, I guess, is, so vitamin D, people are always looking for things it could be associated with, and I just saw a couple of articles in the last couple of years that show that between adolescent idiopathic scoliosis and controls, that there's a higher rate of insufficiency or deficiency. And I don't know if that's people looking for another thing that vitamin D could be associated with, or if you think there could be anything to that. Because a lot of children do have low vitamin D levels, and they don't usually get supplemented, even though the recommendations are to do that now.
I agree. I think that it very well might be an aspect. There are a lot of aspects of it, but especially here in the Pacific Northwest. What I actually see that might be an even bigger aspect of my practice I see are the spondies. I worry that those are from low vitamin D. So I don't put my scoliosis patients on vitamin D. I do put my spondy patients on vitamin D, but maybe I should be putting my scoliosis patients on vitamin D.
Well, it's interesting because the pediatric recommendations now are that all kids are supposed to get vitamin D supplementation, but no one really knows that. And so it was on my toddler's discharge from when she was born, and just to take 400 of IU daily. And it's not a strong recommendation. I don't think any other parents I've talked to know that. So I don't know if it's associated with it, but it's just interesting because when at the last institution I was at, when we looked at adults and their vitamin D levels, we inadvertently had some pediatric patients captured in that trauma database, and they had their rate of vitamin D insufficiency was higher than in adults. Because none of them take, or a lot of them don't take multivitamins.
Yeah. Todd, do you have your, Dr. Wagner, did you give vitamin D? Maybe we should.
So I don't routinely check unless there's family, so I sort of ask as a screening question. But for the few that I have had checked, I would say it's not been a consistent finding. A few have been normal and a few have been low. There is some pretty low evidence about vitamin D and scoliosis I've seen published, leading to relative osteoporosis and that causing or being a risk factor for scoliosis. I would say, again, so many confounders, it's not something that's easy to study.
Okay.
Thank you.
Thank you, guys.